Thank you all for being here this morning. Early as always, this CTN Postdoctoral Fellow Symposium always gets the sort of headline act to start off the meeting, and always in this very large room. But in fact, we have a good turnout, so I'm really pleased to see everybody here, and so thanks for getting up to be with us, because it's really an important moment for us as the CTN and for the postdoctoral fellows. My name's Marina Klein. I'm based at McGill University Health Centre in Montreal, and I'm one of the national co-directors of the CTN. And I'm here with Sharon Walmsley, the other national co-director, who will be speaking in a moment. And just to remind you that the CAHR, Canadian HIV Trials Network Postdoctoral Fellowship Program, is really a flagship program that has been running for now almost 30 years, which offers career opportunities to outstanding young clinical scientists, really facilitating work in HIV, co-infections, STBBIs across the spectrum of research, and building the next generation and capacity for research in this country. We fund candidates who work with mentors in the CTN to write their own protocols, develop their own research, and run their protocol over the course of their fellowship, which is usually 1 year granted and renewable for a second year. And since 1992, we've awarded over 180 fellowships to 112 individuals. And it's important to say that former CTN postdoctoral fellows, including myself, have really come and been developed as Canada's current leading HIV clinical investigators. And so this year, our fellowship awards are available thanks to both the generous contributions of the CIHR through the funding that we receive from them, as well as the pharmaceutical industry. And I'm glad to see many representatives from our sponsors are here this morning, and the Canadian Foundation for AIDS Research, CANFAR. So I get to the pleasure of announcing this year's awardees and the renewals. So for 2024-2025, we have 3 new postdoc fellows, and this is what gets problematic, because I should get people to actually spell them out phonetically, because I often have trouble with names. But our first CTN postdoctoral fellow from the University of British Columbia, who will be supervised by Dr. Mark Gilbert, is Dr. Yogasha Iyamu, or Mui, I think. Our second, who is the recipient of the Mark Weinberg Postdoctoral Fellowship Award, comes from the University of Toronto and will be supervised by 2 former postdocs, Dr. Mona Lutfi and Daryl Tan, and that's Shelza Halani. And our third is Dr. Kathleen Inglis, who is going to be supervised by Dr. Kathy Worthington from the University of Victoria. So congratulations, welcome to a storied club, and we really look forward to our interactions with you and throughout the conference, and please don't hesitate to come up and speak to us at any time if you need advice about where things are going. And then we have year 2 renewals for 3 people, some whom we'll hear from today. Dr. Hajar, Miranzadeh, that's a long name, sorry, Mahabadi, and that's the CTN James Krepner Postdoctoral Fellowship Award, coming from the University of Alberta, and she's going to speak to us today. She's working with Dr. Chris Power. Dr. Monica Kooij, I'm so bad with names, sorry, Kooij, CTN Postdoctoral Fellowship Award from the University of British Columbia, who's supervised by Dr. Melanie Murray and Hélène Côté. And finally, Dr. Tanya Lazor, a CTN Postdoctoral Fellowship from University of Toronto, and at the Center for Addiction and Mental Health, or CAMH, and supervised by Dr. Sergio Ruda. So please congratulate them on having their awards renewed, and we're going to be able to actually have the pleasure of hearing from some of their work in the next little while. So can I ask Sharon to come and start the introductions of our presenters today?
Thanks, Marina, and I share my welcome to everyone. We keep saying every year, why don't you put us in a smaller room so it's not so overwhelming, and it must be hard for our young investigators to get up in such a big room. So my name is Sharon Walmsley. I'm the other co-director. London is my hometown. I was born and raised here, so back to my alma mater. Anyway, today we do have 4 of our fellows going to be presenting their work. The first one is Dr. Francis Mwimanzi, who has the CTN Mark Wainberg Award, and he works at Simon Fraser University under the supervision of Dr. Sabrina Brum. And he has been working on COVID-19 vaccine-elicited immune response among people living with HIV, and this is his second-year postdoctoral fellowship presentation. So please, wherever you are, there you are. Come and give us your talk.
Hello, everyone. Sure. It's Mwimanzi, Dr. Francis Mwimanzi. So yeah, thank you, organizers, for this opportunity to share my 3-year CTN postdoctoral fellow journey. So I've been studying immune responses in people living with HIV in the context of COVID-19 vaccines. A quick background. We do know that to date, COVID-19 vaccines have significantly reduced morbidity and mortality related to COVID-19 infections, whereas prior to that, we do know that people living with HIV were at increased risk of severe COVID-19, so vaccination was particularly important in this population. We do also know that HIV-related chronic immune activation does impair immune responses to vaccines in these individuals. And so it was really important that we do an extensive analysis on how these responses are in people living with HIV in the context of COVID-19 vaccines. And of course, we did extend these analysis towards SARS-CoV-2 variants of concern as they are emerging. So we put together a cohort of people living with HIV as well as controls. We collected samples at these multiple time points. I'll highlight data post-second, third, and post-fourth dose. So these are also some of the assays that we used. So we utilized this critical interaction between the virus and the host ACE2 receptor to generate assays that allowed us to characterize antibody quantity by looking at binding antibody responses and antibody function by analyzing neutralizing antibody responses. I'll start by highlighting data from these published papers. And this is how the neutralizing antibody responses looked like post-second dose. What we saw is that post-second dose, the responses are comparable between people living with HIV as well as control. You do see that post-third dose, these responses are enhanced, and we do see that these responses, of course, do decline over time, and again, they do decline in a comparable manner between people living with HIV as well as control. We had a chance to look at these individuals that went through breakthrough infection, individuals with hybrid immunity, whereby you do see that they do have these remarkable responses. Of course, we did have a chance to look at the responses toward the Omicron variant, where again, you do see similar observation, whereby the responses are comparable between people living with HIV as well as control. So again, we did look at binding antibody responses, where again, you do see that the responses are comparable between people living with HIV as well as controls. And so our take home here is that post-COVID-19 vaccination, people living with HIV do have similar responses to as that of controls. As I said, these responses did decline over time. We did get our fourth dose, and we kept experiencing newer and newer variants. So we thought that it's also important to look at how these responses are. So what we saw is that post dose does enhance these responses, whether they are targeting the wild type or whether they are targeting the even this newer Omicron variant BA.5. However, of course, the responses were significantly lower towards this newer variant. And again, you do see that individuals with hybrid immunity do have these remarkable responses. We had also a chance to look at even newer variants. For instance, we looked at this BQ.1, where the responses were even significantly lower compared to BA.5, suggesting further immune evasive capabilities in these newer variants. We also had a chance to look at T-cell responses. And again, this is what we see, that the responses between people living with HIV are comparable post-second and post-third dose. And both SARS-CoV-2 specific CD8 for T-cells and as well as CD8 T-cells. So enough of the highlights from our published data. We do also have some ongoing studies. So another important aspect of a vaccine is to be able to generate these long-lasting memory B-cell responses. So we thought that is also very important that we take a look at this aspect as well. And so what we did is use this flow-based assay in our lab. The beauty of this assay in our lab is that it does allow you to characterize these responses. It tells you whether these are targeting the wild type or they are targeting the Omicron variant, or they are targeting both the wild type and the Omicron variant. And this is what we saw again, is that the responses are comparable between people living with HIV as well as control, post-second and as well as post-third dose. So we went on to do a deeper look, just focusing on people living with HIV. And again, what we see is that third dose does enhance these responses, and whether they are wild type, they are targeting the wild type responses, or whether they are Omicron BA.1 responses, or whether they are dual reactive, third dose does enhance all these responses. We saw that these responses, of course, persist over time. And again, we did see that individuals with hybrid immunity do have these remarkable responses. Finally, we wanted to see whether these responses can act as a correlate of control. So what we did here is look at the responses for third dose, look at individuals that remain COVID naive and those that went through breakthrough infection 5 months post this third dose. And what you see is that individuals that remain naive do have these remarkable responses that are wild type specific. Of course, we also did see that these individuals do have these remarkable responses that are dual specific. And so we think that these memory B-cell responses can predict breakthrough infection. And so people living with HIV receiving suppressive ART do mount strong B-cell and T-cell responses that are comparable to that of control. We do see that these responses do decline, and they do so in a comparable manner. Again, these responses do decline, and so you do need additional doses. We did see very poor responses towards Omicron variants of concern. And we did see these remarkable responses in individuals with hybrid immunity. And we think that the persistence of memory B-cell does contribute to these robust responses, and they can predict susceptibility to infection. Well, I thought I should also highlight some of the other successes I've had along the way during this CTN Postdoctoral Fellowship. So I was fortunate to receive this Michael Smith Research Trainee Award that allowed me to continue my research on COVID-19 immune responses. I do have a poster if you're interested. You can hear more about the immune amnesia phenomena. Yeah. Also, the award has afforded me an opportunity to go back to providing patient care. So beginning this July, I'll be a resident physician at working in Griffin Hospital as well as Yale University in Connecticut. So with that, I would like to extend my sincere regards to everyone who contributed to my work, particularly my excellent, amazing supervisors at Fraser University, Dr. Sabrina Brumet, Dr. Mark Brockman, my CTN mentor, Dr. Julie Prognac, my SFU colleague, Dr. Peter Cheng, Dr. Rebecca Kalikawe, and Dr. Snea Datwani, and above all, the study participants without whom the study would not be possible. Thank you very much.
So thank you for a beautiful piece of work, and I think everybody can see the value of the CTN Fellowship to enhance someone's laboratory and clinical work. So we will open it up for questions. I think there's a microphone somewhere. Oh, there's one in the middle there. If anybody has a question, come up and ask. As Cecile's coming to the floor, you know, our work has paralleled yours, and one of the comments that we keep getting is, yes, we see immunity, but despite that, we still keep getting infection. So why are we keep taking vaccines?
Wow, that's a tough one, but yeah. I mean, you expect a vaccine to whether help you protect you from infection or prevent you from having a severe infection. So, I mean, it's still working, right? You do have, I mean, it does protect you from severe infection. So, you still have a plus, right?
Cecile.
Just wanted to know if you, oh, okay. Sorry. If you have stratified your cohort according to CD4 counts. So we have similar results than what you were showing in our cohort in Montreal, but we noticed that in people with lower CD4 count,
Yes.
The response after the first dose was definitely not as good, although with booster doses, they were able to pick up the thing. Do you have data?
Yeah, true. So that's one of the limitations of our study. Our study cohorts, the individuals do have very good CD4, very decent CD4 count. So we don't have anyone whose CD4 count less than 200. Yeah. So yeah.
And I think that probably is a huge limitation of much of the work that's been done with persons living with HIV and the vaccines. And so, you know, I think because most cohorts have been well people, it's hard to say, should vaccine strategies be any different? Okay. Well, thank you very much, and all the best of luck with your ongoing career, and we look forward to welcoming you back as your career progresses. So our next presentation is by Dr. Hajar Mahabadi, who is the postdoctoral fellow from the University of Alberta, working under Dr. Chris Power. And she's going to talk about Mpox infection of human astrocytes, causing Gasdermin B cleavage and pyroproptosis. I'm going to learn something here today. So please welcome to the podium.
Good morning, everyone, and at first I want to thank the organizer for giving me the opportunity to be here. Today I'm talking about monkeypox virus infection of human astrocyte causes Gasdermin B cleavage and pyroptosis. There is no conflict of interest for this study. Today I'm talking about the neurotropic effect of monkeypox virus in human neural cells, and I'm talking about the effect of monkeypox virus on Gasdermin B in the brain what's the potential treatment, and the inflammatory pathway that is caused by gasdermin B cleavage in the brain. Monkeypox is a disease that is caused by monkeypox virus. We all know that monkeypox virus is an orthopox virus, and monkeypox it was declared in 2022 by WHO as a global health emergency. The other members of orthopox viruses, we could name variola virus and vaccinia virus. What's the connection between monkeypox and HIV? 40% of people diagnosed with monkeypox in the United States, they also have HIV. And we know that for people with HIV, they may experience more severe illness or death if they get monkeypox virus infection. And this table is coming from a study in different countries that shows that the median age for monkeypox patients, they are around 39-year-old, and almost 100 of the patients, they were identified as men. Monkeypox, it has flu-like symptoms, but in some cases we could find seizure, encephalitis, and encephalopathies. And And here we have MRI of a patient with monkeypox, and you could clearly see the brain lesion in this MRI. And all these symptoms confirm the neuroinvasive potential of monkeypox virus. For today's presentation, we also need to know about inflammasome pyroptosis axis. Inflammasomes are a cytosolic multi-protein complex of the innate immune system. They are responsible for inflammatory response and cell death. Active inflammasomes, they'll active caspase-1, and caspase-1 has a cleavage site in different pro-inflammatory cytokines such as IL-1 beta, IL-18, and it also has cleavage site on a family of protein, we call it gasdermin. This family has different members, and these proteins play important role in inflammatory program cell death. We call it pyroptosis because the active form of these proteins, they move to the plasma membrane. They can cause some pore in the plasma membrane and induce cell death and cell lysis, and at the end pyroptosis. Gasdermin B is a member of this family. It doesn't have expression in rodent. We have it just in primate. And it has cleavage site for caspase-1 and caspase-4. And if you look at, Here you could see that gasdermin B has two domain, N-terminal and C-terminal. And after the cleavage with caspase-1 or caspase-4, the N-terminal and we have the cleaved form of the gasdermin B, the N-terminal and C-terminal, and the cleaved forms, it's an active form of gasdermin B, so they can move to the plasma membrane and induce plasma membrane rupture, and at the end pyroptosis. So in this study, we investigate human neural cell tropism of monkeypox infection. We also examine inflammatory and associated cell death mechanisms in monkeypox virus-infected human neural cells. At first, we infected human neural cells with monkeypox virus. Then we determined the yield of virus by plaque assay after 24, 48, and 72 hours. And here you could, in the graph, you could see that astrocytes are most permissive to monkeypox virus infection, followed by macroglia and oligodendrocyte, and we have the minimal infection in neurons. We also did immunofluorescent staining for monkeypox infected astrocyte. We use DAPI staining for nucleus. We also use GFAP, that is a marker of astrocyte, and we use I3 that has expression in monkeypox. And I need to mention that in this study, I use vaccine as a positive control of infection for my study. And here you could see that we could by immunofluorescent staining, we could confirm the infection of astrocyte with monkeypox virus. And we could also see the morphology change after the infection. Then we did cell death assay. We use green nucleic acid staining, that is the red one. It can bind to the DNA of the cells with the compromised plasma membrane. So we could see that after the monkeypox virus infection, we have more positive staining for green nucleic acid staining that confirms cell death after the infection. I also did lactate dehydrogenase assay. If you remember in the introduction, I mentioned that when we have pyroptosis, we have pore in the plasma membrane, so we have the release of cytokines and also lactate dehydrogenase. So when we have more LDH release after monkeypox virus infection, it could confirm pyroptosis after the infection. Then we did immunoblotting for monkeypox virus infected astrocyte. And here you could see that for monkeypox virus infected astrocyte, we have less pro-caspase-1. It decreased significantly, and it confirms that monkeypox virus infection, it can change pro-caspase-1 to active form of caspase-1. We didn't know about the gasdermin B expression in the brain. So to see what kind of gasdermin protein we have in astrocyte, we did immunoblotting for different neural cells, and we labeled for different gasdermin members. And here you could see that gasdermin B is the only member of this family that has expression in astrocyte. Then we repeated the immunolabeling, but this time we did it after monkeypox virus infection. And here you could see the full length of gasdermin B, that is the inactive form of gasdermin B. But in monkeypox virus infection, you could also see the cleaved form of gasdermin B. And these cleaved forms are the active form of gasdermin B, so they can move to the plasma membrane and induce pyroptosis. Then we were trying to find the treatment to kind of suppress this pyroptosis or decrease it. We know that dimethyl fumarate or DMF is a treatment for autoimmune disease. And we know that this treatment, it could block the interaction between caspase-1 and gasdermin D, and it can block pyroptosis. So if we treat with the dimethyl fumarate, we should block the pyroptosis. So we were thinking it might have the same effect on gasdermin B. So we treated the astrocyte with dimethyl fumarate, and then we infected with monkeypox virus infection. We also used DMSO as a vehicle of the treatment. And you could see that after the treatment, we have less cleaved form of gasdermin B. We also repeated cell death assay after the treatment with DMF, and we find less cell death after DMF treatment. And it confirms that DMF can suppress or decrease pyroptosis caused by cleaved form of gasdermin B. So in summary, I could say that monkeypox prototypically infect human astrocyte, causing morphology change and cell death. Monkeypox activate caspase-1, and caspase-1 can cleave gasdermin B and induce pyroptosis, and it could be decreased by dimethyl fumarate treatment. And at the end, I could say that pyroptosis in astrocyte could underpin monkeypox virus-associated neurovirulence that might be ameliorated by DMF treatment in infected persons. As a future direction, I'm also doing co-infection with monkeypox virus and HIV to see the impact of co-infection on neuropathogenesis. I'm also working on inflammatory pathway that is activated by HIV infection in human neural cells, and I have a poster. If you need more details, I'd be happy to see you there. The last but not the least, I want to acknowledge my supervisor, Dr. Pava, and my lab, all my friends. And I also acknowledge my collaborators and all funding agencies that support this project. Thank you.
So thank you very much. And again, a lot accomplished in the first year of her fellowship. So we open this up to questions. I'm not a basic scientist, but I always bring things back to the clinic. And Maureen and I were certainly involved in the international collaboration looking at Mpox infection. And neurologic involvement is not that common. So based on your model, do you think there may be different strains of Mpox that are more neurotropic? Is there something about an individual that makes them more at risk? And as a follow-up, were you able to get virus from someone who did have neurologic disease to test it in your system?
Yeah, actually we have different strain of monkeypox virus, but it's one of the limitation of our study. We couldn't try all the strain, and it might be because of effect of different strain. Unfortunately, we don't have access to the human brain tissue infected with monkeypox virus.
But Marina and I might be able to help you because we might be able to identify people from around the world that have had neurologic involvement, and if they have one of their strains saved, we might be able to help get that for you. Marina.
If you can hear this, yeah, there we go. Yeah, thank you. Very elegant work and very really interesting. And I echo what Sharon's saying. It was not a huge feature, the neurologic disease. Maybe we're overwhelmed, though, by the clinical manifestations, which are very dramatic in terms of the skin manifestations. And in those cases that were fatal, particularly with HIV, really so much of the disease was like systemic. So there's not surprising that it also could have involved the central nervous system. I was just curious about these types of effects that you're seeing. Would they be, short term, or would you think that they initiate a cascade that could lead to more, longer term damage in astrocytes or in the microglia?
It's a good question, and to see, it's a short term or long term. We need a model to try in different time point and.
Like the pyroptosis that occurs, does that destroy the cells for good? Yeah, so you would think that unless there's some plasticity. I think it's fascinating. The more we see these new viral infections emerge, the more we realize that it's like COVID is a great example of that. They have a tropism for all sorts of tissues that we wouldn't expect necessarily, and then there may be long-term consequences of those infections for people who've been exposed or infected. And with clade 1 outbreak happening right now in Congo, and we have to get ready for that possibility of spread, which much more severe. It would be really interesting to answer Sharon's question about differences in viral clades and their tropism. So keep up the work. I think it's going to be fascinating.
Yeah, and we'll connect you. I think I saw Daryl jump in. Connect with Daryl because he's working with the people in Nigeria, and they have a little outbreak right now, and perhaps we can help you get some strains that might be useful.
Should be good.
Great. Congratulations on a good piece of work, and we look forward to hearing Part B next year. So our next presentation is by Dr. Jeff Wong from the University of British Columbia. He's been supervised by Dr. Deb Money, and I would just like to announce that last month he presented his work at the HIV in Women International Workshop and won the Young Investigator Award at that conference. So again, I would encourage all of our young investigators to present because he gets a free trip to Barcelona on the basis of that. Anyway, today's presentation is my personal journey and future direction, so I'm not quite sure what we're going to hear, Jeff, but we look forward to your presentation.
Good morning, everyone. Thank you for waking up so early. For some of us, it's 5 a.m. where we live. So my name is Jeff Wong. I'm one of the second-year CTN Postdoctoral Fellows. I'm supervised by Dr. Deborah Money. The project that we're working on is to develop a prediction model for preterm birth in people who are living with HIV using our population cohort. The way I'm going to structure my presentation is probably a little bit different than others. I'm really wanting to highlight my journey through the last 2 years with CTN, and it'll be pretty clear why I'm not highlighting the results as much. Before I start, as an immigrant myself from a previously colonized area of Hong Kong, I'd like to acknowledge that I'm presenting on the traditional lands of the Anishinaabe, the Haudenosaunee, the Lenapehoik, and the Attawandaron peoples. I'd also like to acknowledge that I do work, live, and play on the traditional, ancestral, and unceded territories of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations, colonially known as Vancouver, British Columbia. Many of you have no idea who I am, so I just wanted to kind of give you a little trajectory in terms of how I got to where I am with CTN. As a gay male myself, I've always, throughout my youth and early adulthood, I've been the target demographic for a lot of the AIDS service organizations for HIV prevention. Eventually made me interested in the field, and I volunteered with the Asian Community AIDS Services, which is an ASO in Toronto. And then where I worked on the men's outreach team, completing bathhouse outreach, nightclub outreach, and other types of promotional activities with the organization. I then went into medical school at the University of Toronto. He probably doesn't even know who I am, but I actually went with Dr. Mike Silverman when he was still with the University of Toronto. I worked on a project where I went to Zambia to investigate the perinatal outcomes of people living with HIV. And the middle picture is a picture in Zambia with the team when I was there. I wanted to be an adult HIV physician, like adult ID HIV physician, or an HIV primary care physician. But throughout my clinical rotation, my life trajectory completely changed because I fell in love with obstetrics and gynecology. And that prompted me to move to Vancouver, British Columbia to pursue my residency there. It's also there where I met my mentors who showed me how I can combine my interest in HIV care along with obstetrical and gynecological care as well. And that's where the CTN came in. It provided me an opportunity to bring the two interests together. And the project that I worked on was to develop a prediction model for pregnant people living with HIV using our cohort. But it also enabled that I had 25% of my time dedicated to some clinical training, working with the local team at the Oak Tree Clinic, with the obstetrical side, including Dr. Deborah Money, Dr. Julie Van Skalkwyk, and Dr. Chelsea Elwood. I also had the opportunity to go out of province to work with Dr. Mark Uden at the University of Toronto and Dr. Vanessa Poliquin at the University of Manitoba as well. The main reason why I'm not highlighting a lot of the result is because you're all going to hear about it in a little bit. So I'll have an oral presentation highlighting the intersection of concurrent sexually STBBIs for preterm birth in pregnant people living with HIV, and that's on Sunday morning. There's also a poster in the poster fair highlighting the effects of substance use and preterm birth in pregnant people living with HIV. So I didn't want to repeat the same talk twice. From a prediction model, this is work in progress. So I just wanted to, the goal of the prediction model is really trying to identify clinical and statistically significant variables that put individuals at higher risk of preterm birth, so that we're able to develop a preterm birth prediction model that's individualized for each patient, so that when people come into our clinic, we're able to provide that personalized medicine. But this is still kind of in the works, so completely work in progress. I just wanted to take a moment to talk about what CTN had to offer. I feel like an ad here. But what CTN had to offer me as a CTN Postdoctoral Fellow. I attended 3 CTN meetings, and which were fascinating because it provided me the opportunity to learn about advances in HIV care and prevention strategies here that's taken place here in Canada. It also allowed me to take the opportunity to review scientific proposal as part of the postdoc work with the Scientific Review Committee. And I think one of the most interesting parts of the CTN Postdoctoral Fellowship is the invitation that we get to attend the Community Advisory Committee meeting, or CAC meetings. It's an opportunity that I think not a lot of clinicians or researchers have the opportunity to get that community perspective. And I thank the CAC members for inviting our postdoc cohort into their committee meetings. Through the CTN network, I have then been able to be included in a lot of initiatives, such as the parenting guidelines for people living with HIV. Also became a co-investigator in a breast milk and viral dynamics study through the CTN as well. The CTN also provided me lots of opportunities to get involved outside of the CTN. So our training coordinator, Julie Pongrak, sent me this link to apply for the International AIDS Society Mentorship Program, which basically matched me with a mentor in Kenya, who's a senior research scientist. And it's really interesting because at that point, I was able to discuss in terms of global health partnerships. And it's also interesting because me from a high-income country, and he's in a low-middle income setting, but I'm situated as a mentee and he as my mentor. It really allowed for open communication in terms of what it means to provide a sustainable partnership in global health research. So I thought that was really interesting. The IAS also provided me the opportunity to attend sessions on gender and stigma, which I bring back to my research and clinical care as well. And they were very generous in supporting my attendance to the IAS conference in Brisbane, Australia last year. Other things that I was involved with, aside from HIV, as many of you know, we are struggling with a syphilis outbreak across the country and in British Columbia as well. So I'm a co-investigator in a project developing the National Perinatal Syphilis Surveillance Database, and we were lucky to receive 2 CIH grants just this past February and March. I also received a local research training award to help with this project as well. And I was partnered with the University of Rwanda through our university to try to understand and reduce surgical cesarean section surgical site infections in 7 district hospital as well. And this was submitted for a CAHR spring grant as well. Dr. Walmsley basically stole my thunder on this, but basically I wanted to, during my CTN fellowship, I had some successes, and I just wanted to highlight that. A couple weeks ago, I presented at the International Workshop for HIV in Women in Washington, D.C., where Dr. Walmsley said I received the award, so I'm very grateful for that, and you can see how proud my mentors and CTN investigator, Dr. Deborah Money and Dr. Chelsea Elwood, are in the picture on the left. I also received this award from JAMI, the Journal of Association of Medical Microbiology and Infectious Diseases, on a trainee published manuscript award. It's working on a project that highlights the antimicrobial stewardship that we can complete in an obstetrical population as well. So what's next for me? I've also submitted some abstracts to IDSOG, which is the Infectious Diseases Society for Obstetrics and Gynecology, one on Hansen's disease in pregnancy, which is previously known as leprosy, and one understanding penicillin allergy delabeling in the pregnant population. I'm also going to be attending the University of Washington STI and HIV research and public health course in July, so I'm really excited to learn a little bit more from colleagues across the border. And I will be completing my fellowship in August of 2024, and the goal is that I will be publishing the manuscript on the project that I outlined for you previously on the prediction model for preterm birth using our British Columbia cohort data. And I'll be challenging the HIV specialist designation with the American Academy of HIV Medicine as well. And then in October 2024, I'll be starting my adult job, my big boy job, of becoming a reproductive infectious disease specialist at BC Women's Hospital, where the Oak Tree Clinic is situated, also with affiliation with St. Paul's Hospital as well, and with a clinical faculty appointment at the University of British Columbia. So I know this is slightly different of a presentation than probably many of you expected, but I just didn't want to repeat my CAHR abstract presentations. But I just wanted to take the opportunity to highlight and showcase what the CTN Postdoctoral Fellowship has allowed me to do in the last 2 years, and I'm very, very grateful for that. I'm very grateful for the research team that I have, and also for Vive Healthcare, who is the sponsor for my specific fellowship. And I want to give a shout out to the BCC3 teams, especially because they were very, very important in helping me interpret my results, especially because they have a lot more experience working with women and people living with HIV. I see them in their pregnancy, but then they have a breadth of knowledge outside of that as well. So I really thank them for being part of the clinic, and I see all the amazing work that they do in parallel, and it's really exciting as well. So thank you for listening.
So thanks, Jeff, and I think we'll put them on the road, and really describe, what the value of this fellowship is and how much people can learn and grow and have experiences over the course of 2 years. And again, a shout out to our pharmaceutical partners for helping us sponsor this. This is really money well spent, and look how much Jeff has been able to accomplish in a short period of time, and encourage others to make sure that we attract all of our young investigators and keep them in the fold. And Jeff, we're glad you're going to be involved in HIV in the future. Kind of hard to ask a question around this, but if there is, but I will ask one, is prediction models. Normally you develop it within one cohort, which I assume you're using the BC group, but then you need to test it in another. So which cohort are you going to test it in?
That's a great question. So I feel like most of it the automatic answer is probably the CHPSP, like the Canadian one. The only issue is that a lot of the variables that we collect in BC we're not collecting the Canadian one, so it becomes a little bit more difficult to validate with that. So that means we have to, the most likely one that we will use is actually the Quebec database, because with Dr. Isabelle Boucourant, once she finished her CTN Postdoctoral Fellowship, she moved on to Quebec to kind of bring our perinatal database from BC to Quebec. So there is some data from Quebec that we can validate with.
Okay, thank you, Jeff. Okay, and our final presentation this morning is by Dr. Katherine Kooij, who is the CTN Merck Postdoctoral Fellowship awardee. She works at Simon Fraser University with Dr. Bob Hogg, and her presentation this morning is working at the intersection of two public health challenges in British Columbia, HIV and drug toxicity. So welcome, Katherine.
Good morning. Thank you for the opportunity to present my work here today. My last name is actually Kooij. But other than that, I'm very happy to be here this morning. I also took a little bit of a different approach for this presentation. I would like to walk with you through some of the highlights of my CTN fellowship and what I've learned. But first I would like to acknowledge that this work was done on the and unceded territories of the Coast Salish people or in Vancouver. I have no conflicts of interest to declare. As the title of this presentation mentioned, British Columbia, as many other places in North America, currently deals with two public health challenges. There's HIV and there is the drug toxicity crisis. The HIV epidemic is under control or is virtually ended, but some populations are not doing as well as others. This is a very old study that I'm showing here as an example, but newer studies have shown similar results. For example, life expectancy is increasing of people with HIV overall, but among IDU and among groups such as women, it's not increasing as much. The drug toxicity crisis is particularly affecting people with HIV. As shown in these results, people with HIV, a large proportion of the mortality is due to causes related to drug use. So my postdoctoral fellowship was focusing on one little puzzle piece in this intersection between these two public health challenges. The focus of my postdoctoral fellowship was non-fatal overdoses and specifically the linkage to care in people experiencing a non-fatal overdose to improve this linkage and avoid fatal overdoses and other consequences. However, what I will focus on in this presentation is a little bit of the other work that I've been doing around the same topic space, because the main work is still in progress, and I've done a lot of other work which I would like to go through. Most of my work in my postdoctoral fellowship was making use of the COAST study data, which is a linkage between the BC Centre for Excellence Drug Treatment Program and Population Data BC Administrative Health Data. Virtually all people with HIV, as well as 10% of the general population in BC, is included in the cohort. And data are available between 1992 and 2020, with currently an update in progress to 2022. For these people, clinical data as well as administrative data, including insight into many social structural factors affecting health, derived from census mostly, is available, allowing for assessing their health outcomes and health care utilization patterns. So one of the projects that I've been working on is focused on life expectancy and mortality, as we wanted to assess whether the increases in life expectancy that have been observed were how that pattern continues more recently, and whether the gap that was observed earlier between males and females was closing. However, we observed that life expectancy, although it increased over the last years, the gap between males and females only has increased. When we assessed whether, to what extent this could be explained by social structural factors, overall all-cause mortality can, to some extent, the differences between the sexes can to some extent be explained by social structural factors. And if you look at individual causes of death, communicable disease and injuries and external causes can largely be explained by social structural factors. However, non-communicable disease mortality was still increased even after adjusting for social structural factors. The second part was looking at non-fatal overdoses among people with and without HIV, and also assessing whether this was different between those two groups. And what we found here is that non-fatal overdoses, as we expected, were much higher in people with HIV, and what we did not clearly expect but very obviously saw is that the highest rates were observed among females with HIV. And these differences could not be explained by sociostructural factors completely. I continued on looking at a very specific aspect of attending the emergency department with an overdose, as one of the objectives of my study of my project was to assess linkage to care in people who experience an overdose. A precondition for that is to attend healthcare and to complete your healthcare visit. So I assessed determinants of completing care, which means being assessed by a physician and receiving a diagnosis. And what I found there was that people living with HIV who attend an emergency department with a suspected overdose leave more frequently than people without HIV without completing care. In this graph, you can see that this difference was observed throughout the study period. And when we looked at determinants of leaving the ED without completing care, these were determinants identified in the group of people with HIV. And what I would like to draw attention to is that you don't see a difference between males and females in the ratio of leaving the ED without completing care, whereas this is the case in the general population. Males are more frequently leaving without completing care, and more recent period we saw more frequent leaving without completing care. So there's an increase in this phenomenon. So in conclusion of these aspects of my work, I would like to conclude that the ongoing drug toxicity crisis seems to exacerbate some barriers and challenges that are experienced by women with HIV, and this may contribute to the increase in gap in life expectancy that we're observing. Further research is needed to better understand the factors underlying these sex and gender differences in health outcomes and healthcare utilization patterns. We have access in this study to mostly census-derived sociostructural factors determining health, and this is of course limited, but there is more work that I'm working on and that can be done, and these findings emphasize the need for a women-centered care model serving women with or at risk for HIV infection. I would like to thank you for your attention, and I would like to acknowledge my supervisors and my funders, and thank you for your attention.
So thank you for this good work, and clearly this is a really important area to continue to evaluate. Daryl.
Hi, Katherine. Great work. Thanks for the presentation. I was interested in the last of your data slides there about leaving the emerge before completing care. In your model, it looks, I was pretty quick, but I think most of the variables you had in there were kind of patient-level kind of characteristics. But I was wondering to what extent you were able to account for system characteristics in that modeling. Your last point on your conclusions was we need women-centered models of care, and likewise we need models of care that are welcoming to and non-stigmatizing to people who use substances, and we all know that that's not often the case. Were you able to account for, it's a very difficult thing to measure, I'm sure, but some kind of acknowledgement that maybe it's the system, not the person, that's not matching, and also just the very logistical consideration of like how busy was the emerge that day, and how long would have been the wait time.
Yeah, thank you for your question. That's a really great point, and that is actually one of the limitations that I realized when I was doing this study, that the determinants that we actually are able to assess are less affectable. It's less possible to affect these, to make changes than I originally wanted. And system-level measures, we have the wait time we can take into account, and we can look at the health authority, the area where the care was delivered, and other factors of the ED. We don't have real data on in this study.
Maybe even, I'm just riffing off things that you're saying, but maybe even like area level characteristics, like how urban was the hospital, where you might expect that, or some area level measures of like the extent of the epidemic that could be measured at the area level to which the hospital to which the person presented. You know, those might be ideas.
Yeah, thank you. We can look more into that. It's a good suggestion.
So in your work, you found that women had a higher incidence of non-fatal overdose. Is that because men were more likely to be successful, or women were more likely to have an attempted overdose period?
No, there's both is higher in women. Yeah.
And you also showed a peak in 2016, I think, on your graph,
Yeah.
and then it dropped. Why do you think it dropped?
Yeah, that's interesting. And of course, we can only speculate about that. But it might be that there was some success in the measures that were taken around that time when the overdose public health crisis was called in that time. But other than that, there's just speculation. I don't know of any other concrete measures that were taken in that time that could have affected that.
Okay, are there any other questions for Kathleen? And if not, I will take this opportunity to close this session. So first of all, I'd like to thank many of our fellows for coming and doing their presentations today. I think the pandemic, this particular set of residents or postdocs, the pandemic, we never got to see much of them in person, so I'm so happy that we actually been able to see you in person, and sorry for Marina and I screwing up everybody's names. We apologize. I'd also like to thank all of the supervisors. So our postdocs cannot do this good work without your support, and we thank you all for that. We also thank our sponsors. Again, without your help, we need that money to help support these fellows, and I hope that you're all very pleased by what they've done and what they've presented today. And lastly, of all the audience, this is, I think, the most we've ever had at our postdoctoral fellows session, and at the crack of dawn in London, Ontario. Thank you all for coming, and we hope that you all have a good conference, and we're looking forward to seeing you again next year and seeing our new fellows and the work that they do. So thank you all.